criteria. We excluded studies that had designs different from clinical trials and studies that did not include pharmacological therapies. So we did not include clinical trials that were investigating only surgery or only radiotherapy, but trials that had at least one pharmacological therapy. We searched in two different databases, which were the clinicaltrials.gov, which is the largest clinical trial register, and also the WHO International Clinical Trials Registry platform. Also, we searched for the included clinical trials. We searched for the publications that they had in PubMed and Medline. The results of the PRISMA flow diagram review were that in the end, overall, 779 records were identified in both databases. As you can see, more from clinicaltrials.gov. After removing 85 duplications, 694 clinical trials were eligible for screening. A total of 482 records were excluded for several reasons. For example, not including rare gynecological cancers, studies on prevention or quality of life, medical procedures such as radiotherapy or diagnostic procedures. We excluded also observational studies and preventive vaccines. So, in the end, finally, a total of 212 records covering trials recorded during the period 1993 to 2022 were included in the final review. Also, related to the type of cancer, we have to highlight that 90 clinical trials, so that is 42.5% of them, included only patients with rare gynecological cancers, whereas 31%, so 67 clinical trials, included patients with gynecological cancers encompassing at least one rare type, and 55, so 26% clinical trials included patients with various types of cancers, among them rare gynecological cancers. So this highlights that often clinical trials for rare gynecological cancers are carried out with other types of cancers. So just 42% of them were only for rare gynecological cancers. Also, we identified only one basket trial, which was a multi-center phase 2 trial of nivolumab and ipilimumab as dual anti-PD-1 and anti-CTLA-4 blockade in rare tumors. So, as a result, you can see in this figure summarized the number of clinical trials investigating therapies for rare gynecological cancers, and we can see that it has increased over the years, reaching 79 clinical trials initiated in the period from 2017 to 2022. And this figure shows the number of clinical trials for these malignancies stratified by the type of therapy over the years. Moreover, the most evident finding is the increment in trials involving targeted therapy. So you can see the orange color is targeted therapy, and we can see that from 1 it rises to 4 to 8 to 14 and finally to 35 in the last 5 years. So 35 new clinical trials on targeted therapy started in the last 5 years compared to just 26 from 2000 to 2016. Furthermore, in the last 5 years, there has been an increase in clinical trials investigating a combination of therapies, which is mostly with this mixed, so the yellow one, in the last 5 years, and also a decrease in clinical trials focused on chemotherapeutic agents only. So we can see that the blue color has decreased. So they show the chemotherapeutic agents only. This trend follows the same direction as in treatment regimens of other types of cancers, explained by the introduction of novel therapies with new mechanisms of actions. According to a report published by IQVIA, a paradigm shift in oncology drug expenditure from chemotherapy and hormonal therapy to more targeted approaches has occurred over the past 25 years. The most common type of therapy investigated in clinical trials for rare gynecological cancers was chemotherapy. So in 89 clinical trials, that is 41 or 42% of the trials, then followed by targeted therapy in 30% of them, and mixed therapy. Mixed therapy was generally a combination of chemotherapy and targeted therapy. Hormonal therapy was rarely investigated, so we were able to find only 6 trials. Similarly to other therapies, which were only 4, such as propranolol, radiation modifier, triapine, and VCN virus. So there were other therapies, but rarely. So we also have to emphasize that 26 of the trials, so it's 12% of them, were terminated or withdrawn due to various reasons, such as lack of accrual or low accrual, which was reported in 8 clinical trials, and we know that this is a problem for rare pathologies. Because of lack of approval by the ethics committee, because of sponsored decision to withdraw funding, which is also a problem in rare pathologies, and also other reasons such as principal investigator departure from the institutions or due to toxicity. It's not written here, but I also have to emphasize that there was an underrepresentation of children eligible to be included in these clinical trials. So only 12 or 13% of the clinical trials had children eligible to participate, whereas older patients were eligible to participate in 98% of the trials. So for the clinical trials in rare pathology, we don't see discrimination or a low participation of older adults. On the contrary, we see that older adults are eligible to participate in most of the clinical trials. Classification of pharmacological therapies, we mentioned it before that we classified them in chemotherapy, targeted therapies, hormonal therapy, and others. So this was the one that were observed in the clinical trials that we included in our review. So for chemotherapy, for example, it were alkylating agents, which I must say were a lot of them, separated into a lot of groups, such as nitrogen mustards, platinum-based, tetrazine, purine analogs, and they were all represented in these clinical trials. Antimetabolites, such as, for example, purine antagonists, pyrimidine antagonists, and antifolates. Also mitotic spindle poisons, for example, vinca alkaloids, taxans, and microtubule inhibitors. And also others, such as antibiotics, such as bleomycin or mitomycin, proteasome inhibitors, such as bortezomib, and others. For the targeted therapies, we classified them into overgrowth-related targeted therapies, angiogenesis-related targeted therapies, and immunotherapy. However, there is a discussion that we have to probably, it's better that immunotherapy, we have to analyze it separately from the targeted therapies. So we are currently doing this now. But for the overgrowth-related targeted therapies, for example, we saw many drugs that are being investigated in these clinical trials. For example, HER2 inhibitors such as trastuzumab, mTOR inhibitors such as everolimus, temsirolimus, PARP inhibitors, MEK inhibitors, ACT inhibitors, also many others. I'm not mentioning them all. For the angiogenesis-related targeted therapies, also tyrosine kinase inhibitors, FAK inhibitors, VEGF inhibitors, EGFR inhibitors, and we are going to see immunotherapy in a later slide. For hormonal therapy, we did not find so many clinical trials, so we're only 6 clinical trials investigating them. But these 4 groups were included. And also there were others, drugs, that are not classified into the 3 previous groups. For example, a big one is metformin was a drug that was investigated, the oncolytic adenovirus, and the radiation modifier triapine. Here we see a classification of the immunotherapy. Immune checkpoint inhibitors, for example, the inhibitor of CTLA-4, ipilimumab, inhibitor of PD-1, so programmed cell death 1, nivolumab and pembrolizumab. There were also others, but here we mention some of them. And inhibitors of both, the vudalimab, inhibitor of PD-L1, which is atezolizumab and durvalumab, inhibitor of TIGIT, etigilimab, and also others. So there are many more. Another group was tumor vaccines. So they were investigated also in at least 4 different tumor vaccines were investigated in these clinical trials, and CAR T-cell therapy, which is a very new approach to pharmacological therapy in cancers. Also CAR T-cell therapy, there were 4 different therapies that have been investigated or are currently being. So here we see some of the mechanisms of actions of the therapeutic interventions of some of the therapies. For example, the main classes of anti-angiogenic agents are anti-VEGF, so vascular endothelial growth factor, monoclonal antibodies, for example, the bevacizumab that we see here. Also soluble VEGFRs, aflibercept, which is this one, and also tyrosine kinase inhibitors. Tyrosine kinases are enzymes that catalyze the transfer of phosphate from adenosine triphosphate onto target proteins to elicit a response. Tyrosine kinase inhibitors, as these drugs that we can also see later too, are small molecules which can block intracellular tyrosine kinases in multiple signaling pathways. Here we have the PARP inhibitors, which were olaparib, rucaparib, and niraparib, and their mechanisms of actions. So the PARP poly-ADP ribose polymerases inhibitors. And here are the therapeutic interventions on hair, which is human epidermal growth factor receptors, also known as erythroblastic leukemia viral oncogene family, which include HER1, HER2, HER3, and HER4. These ones. Hair-targeted drugs include monoclonal antibodies and small molecule inhibitors. Monoclonal antibodies against the extracellular domain of the hair receptor include cetuximab, nimotuzumab, trastuzumab, pertuzumab, and adotrastuzumab. Whereas small molecule inhibitors are tyrosine kinase inhibitors, which include gefitinib, erlotinib, lapatinib, and afatinib. So here we have the immune checkpoint blockades. As we saw, ipilimumab, which is CTLA-4 inhibitor, and the pembrolizumab, which is anti-PD-1 antibody. You can see their mechanisms of action. So, as a discussion, in the included clinical trials that we have reviewed, One of the points that we have observed was a clinical study design, and there was only little variation in the design of completed clinical trials, which were most open label, so no masking, with single group assignment, and allocation was not applicable as they were single arm trials. Results of the clinical trials were unpublished in 65% of the completed clinical trials. So even in the completed clinical trials that have finalized, 65% of them had unpublished results, and 45% of them had neither publications nor had posted any results. These findings highlight the need for higher quality clinical trials and better reporting of data from the current ones. We also calculated the JADAT scores for the completed clinical trials, and the JADAT score was more than 3 only in one trial. So from the 79 completed clinical trials, all of them had a JADAT score from 0 to 2, which shows the low quality of the trial. The limitations of the study, so we did not include trials that investigated radiotherapy, surgery, or other procedures, as this particular review was focused on clinical trials comprising at least one pharmacological therapy. So these could be studied in future systematic reviews to further shed light on the existing literature. Also, our study may underestimate the number of basket trials, as they often they include many different types of cancers which exhibit the same biomarker or mutation, but without specifying the site, morphology, or histologic diagnosis. So we could not identify it with the inclusion criteria we had. Furthermore, the majority of clinical trials lacked, as we said, published results and or publications, making it difficult to extract such information. So basket trials may be underestimated. As a conclusion, this systematic review gives a snapshot of pharmacological therapies investigated in clinical trials for rare gynecological cancers and their characteristics. The paucity of high-quality trials limits evidence-based decision in clinical care. Therefore, it is essential to design and implement novel trials with good quality and better reporting of results. Establishing international networks focusing on rare gynecological research, from basic research to cure, such as Gynocare, needs to continue to be encouraged in order to reach out to the key stakeholders. This will bring together experts in basic science research, pathology, oncology, surgery, gynecology, pharmacy, and other specialties, together with lawyers, ethicists, and data protection officers, in order to help bridge the gap with pharmaceutical companies and industry and lead to effective, well-designed clinical trials which will start to address the lacunae in our current knowledge of how to best manage patients with rare gynecological cancers. Thank you.
So thank you very much, Kleida. Very interesting presentation. Do we have any questions? Yes, there is one from Dr. O'Toole.
Thank you. A really nice presentation, and it's really valuable to have that data. So well done. Just to comment, or just to get your opinion, really, why do you think there's so few hormonal therapies?
Yeah, we have put that in the discussion too, because we saw, for example, in an article about prostate cancers, for example, the majority were hormonal therapy. So this was a drastic change from our results. But we discussed that probably it's a different mechanism of pathogenesis, and probably there are not so many therapeutical options available on hormonal therapy. But we don't have a clear answer, of course. But that was very obvious. That was very rare. Hormonal therapy was very rarely investigated in rare gynecological cancers. So it was only 6 trials that we found out.
Maybe to do with the pharma and more money from the targeted therapies is also
probably. Probably. In the last years, yeah, we have seen that.
So thank you. Are there other questions? Not seeing any questions on the chat. So thank you very much for the interesting presentation. And now we move on to Dr. Mariella Vasileva Slaveva. I hope I got your surname correct. Sorry, Mariella. I've known you by first name. So basically, Mariella, she is a surgical oncologist from Bulgaria, and she's going to speak to us about cancer of the uterine cervix in Bulgaria and epidemiology of a crisis. And basically this ties with what Dr. Gemma Gatta has told us before the lunch break. So the floor is yours. Thank you, Mariella.
Thank you. Is it seen? Yes. Okay. Okay, so thank you very much for the invitation. First, I want to start with this. The idea of this project started in Malta, and it couldn't be done, and it's not done yet, without the help of my colleague, Dr. Jordanov, David, Noya, Neville, and Jean. So I really hope it's just a beginning of very fruitful work that we will do. So cancer of the uterine cervix in Bulgaria, epidemiology of a crisis, and why crisis? Because actually in Bulgaria there are many crises. One of them is demographic crisis. Since the last counting of the population in 2011, Bulgaria has decreased their numbers, the numbers of the population, with over 800,000 people, or more than 11% of the population has diminished. What's happening with the women population in this time? So more than 200,000 women less we have in 2020, and you can see here what's happening with the distribution according to age in different age groups. So it's visible that we are getting older and older. These slides I showed in Malta, actually, they show that cancer of the uterine cervix, as Gemma Gatta said, is actually a lot in Eastern Europe and in Bulgaria, in Romania, and in countries with very well-established screening program like Malta here. Actually, the cancer of the uterine cervix is a rare disease, but this is not the case in Bulgaria, where we have about 90-20 cases per 100,000, so very far from rare. What we did since our last meeting, we took data from Bulgarian National Cancer Registry from 2013 to 2020. And what we find out? We find out that, yes, the numbers in cancer of the uterine cervix are actually decreasing, but still we have, on average, about 900 cases per year. You can see here that actually we are getting worse in diagnosis, because in the more recent years, people are diagnosed in more advanced stage, and also the older person is at diagnosis, the higher is his chance to get an advanced disease. So it's getting worse. And here are the numbers. You can see that in 2018, 19, 20, actually we have a decrease in the new cases, and of course it can be COVID, it can be just delay in registration of cancer patients in the registry, and it's for me the biggest reason is actually the decrease in population that we have, but still 900 a year. It's here. So besides the high number of new cases, also the mortality rate is quite high. Bulgaria is on the fourth place in Europe. Here we are in mortality. And for example, in 2015, 830 women have died from cancer of the uterine cervix in Bulgaria. 120 were under the age of 40, and over 600 were under the age of 65. So we lost here the childbearing opportunity and also the working incomes. What about survival? Actually, we did, so survival, again, in Bulgaria is about 10% lower than in other European countries. Actually, we have an improvement in survival. Here you can see that the patient treated after 2017 actually have slight improvement. So we are probably going on the right way, but we are still far from there. Now, this was very interesting analysis to do, and this is one of the things that I actually want help from you. In Bulgaria, we don't have a national screening program for cancer of the cervix. We had few attempts for improve early diagnosis, but they covered a very small amount of patients finally, of women. So, one very important information you can see here on the graph. Women aged 20-25 are much less than women aged 40 to 50. In 2022, something happened. We had a new contract with the government, the doctors and the government, and we increased the price for pap test from €5, this was all that state is paying for one pap test, to €15 per test. So, if 100% of the population is covered, this means that before 2022, the state will give over €8 million per screening annually. After this year, 2022, the state will give €27 million for screening with the new prices of the test. Actually, the state is planned to cover before 2022 only 10% of the population, and now they are planned for 20%, so about 300,000 women. What would happen if we introduce HPV genotyping in screening programs? For women between age of 20 and 30 every 3 years, and for women 30 to 60 every 5 years, this will cost €16 million. So 1/3 less than the current price actually of the screening. But what is even more interesting, we try to calculate how much actually costs the treatment for these patients. And you can see here, this is a percentage of how many patients for 1 year, if we say we have 900 patients average, so how many will be stage T1A, T1B. You can see that 50% of patients will be actually higher stage. How much it costs the treatment for each of these patients according to the stage. And you can see that, yes, patients in more advanced stage costs much more to the state. But totally, these 900 patients cost just below €2 million per the state per year. So I will have some questions at the end. In Bulgaria was recently actually accepted the anti-cancer plan, and the only thing that this anti-cancer plan says for cancer of the cervix is that pap test should start after the age of 35. We expect something to happen in 2025, and so my question would be for you, so it looks like it's cheaper to treat the patients in Bulgaria and less to screen them, because most of the procedures are very much underpaid. So I suppose it's not only in Bulgaria this case. And yes, so maybe you can help us collect this data, make better analysis, and we'll be very happy. And with this, I would like to thank you for the attention.
I must admit, this has been very, very interesting, and I mean, a bit shocking as well. I mean, shocking not only because of the rates of cervical cancer, but even when you calculate costs, which for sure, I mean, need to be analyzed and interpreted very correctly to ultimately, of course, lead to improvement in health. So, are there any questions? Yes, I expected Dr. Gatta, and then Professor Grigor.
Thank you very much for your presentation. I know the situation of your country, especially for survival. And I have to say that you are very courageous, very active in improving the situation. So the question is, what you propose about screening and treatment, it is absolutely necessary to evaluate both the effect of screening and treatment and diagnosis for this type of cancers, which is not so rare in your countries. And you need a very good national cancer registry to do this. So I don't know which is the situation of your registries, because it was very good in the past. We use a lot the data for to study many types of cancer, also common. But it's important to continue to have a continuous surveillance of this. And I know that the government of your country now decided to have a different kind of registry, population-based, but using a different kind of sources of data. And probably we will not see anymore, or not anymore, in the close future, good data from your registry. So it's important also to contact the politicians that are involved, or the organizer of the to have a good registry. Otherwise, we cannot evaluate the effect of your.
Yes, it's really a problem. I know this. What I know is that in the anti-cancer plan they have included establishment of a new registry. But honestly, even with I think it's not a good idea personally, because there are already infrastructure which is working, maybe not the best way, but with some regulatory improvement, it can work better. But the only thing that is actually written in this plan, which is 140 pages, but they don't say how they will do it, who will collect the data, how it will happen. They just said they will do a new one, most probably, and that's it. And actually, I tried to contact media about this and said, okay, there is something which was maybe working, now we are destroying and investing a lot of money again to invent something that maybe, who knows if it will work or not. They said, well, it's in the cancer plan, so it should be fine. So that's it. And yeah, of course, we keep on working on this. I think that actually using the data from the cancer registry is one of the ways to show how important it is, because if we don't have this data, we will not know how many patients we have, how much they cost to the state. All this will be lost. So now is our chance, until we still have it, to show it. So yeah, thank you.
Thank you. And I think we have another question from Professor Grigor.
Well, I have to comment. It's a tragedy that actually the treatment in our countries costs less than the prevention, which is totally out of question in other countries. If the treatments are so expensive, or probably, as previously Professor Mandic says, we are not using the expensive drugs and we don't have them, so that's why the treatment is cheaper, but the results and the survival rates probably are not as good as in the other countries, as you showed in your graphs. My question is, what is actually, do you have the numbers, what is the average coverage of the women with pap smears and with HPV per year? Because this estimation of prevention was like for 3 years for young women and 5 years for older, and the pap smear was probably per year.
Yes.
So how many women do you cover per year?
Well, I'm sorry I didn't put this. We don't have a screening program. We only have just some national programs for improving early detection. They happen here and there. What I can say that every year the National Cancer Fund, the National Insurance Fund, should receive about 4 million left, so 2 million euro from the government to cover the PAP tests. And they are aiming for 20% of the population now. But I don't think they get this 20% in any way. So, yeah.
Thank you very much. And you'll certainly find help to get this data published, because it's very important, and the discussion will definitely raise many, many issues. Yeah. Thank you. Okay, so now we move on to our next speaker. This is Professor Noya Galai, who will be joining us from Israel. She actually might be in the US at the moment. No, you're in Israel, yes. So from Israel, Professor Galai, so she is a professor of biomedical statistics, and she is from the University of Haifa in Israel. So, Noya, the floor is yours. Thank you.
Okay, let me try and share my screen. So, just the outline, I'm going to give you a little bit of background about incidents and screening rates among women in Israel. Give the study motivation, design, discuss results, and hopefully give you some ideas about implementation of screening policies. So this is the picture of cancers among women in Israel in 2019. And these are the most common types of cancer, and the data comes from the Israel Cancer Registry, that is kind of under the Ministry of Health. And we can see that by far the most common two cancers among women are breast cancer and colorectal cancer, which is at the bottom. And that's true both for Jewish and Arab women, where breast cancer is about 30%, a third of all cancer diagnoses in that year, and colorectal cancer is about 10% of all cancers among women. And correspondingly, the mortality rate for breast cancer is 18 or 24% for Jewish and Arab women, and for colorectal cancer is again about 10 or 9% out of all cancer mortality in that year. So that's just a very general background. And to connect a little bit to the type of cancers we're discussing in this meeting, these are the incidence rates over the period from 1980 to 2013. That's as far as the record, the public records of the cancer registry are given, and you can see before by far the breast cancer incidence is very high, about 150 per 100,000 after age adjustment to the standard population, while the cervical cancer in orange here, uterine cancer in blue, and ovarian cancer at low rates, but still we see a slight trend of increase up to 2013 for both cervical cancer and uterine cancer. And the rates are about kind of 10-20 per 100,000. Okay. So cancer screening, for both breast and colorectal cancer, that are the most common cancers among women in Israel, there are widely used guidelines for early detection. And for colorectal tumors, we have various modalities of screening, including fecal oral blood test or FOBT, endoscopy, colonoscopy, computerized mammography, colonography, and similarly for breast cancer, we have mammography that is performed every 2 years. And we all know that screen-detected cancers are generally of lower stage and are associated with improved survival compared to interval cancers or those among the unscreened population that are discovered not on routine screening. And here is a graph of a publication from 2021 showing the trends in cancer screening rates among women. The top pale gray line shows the breast cancer screening rate, and you can see it's going up from about 50% in 2002 to about 70% by 2017. Below is the screening for colorectal cancer that showed an increase from 10% to just about 60%. And here the shorter line shows the screening for cervical cancer, where the data was collected starting from 2012, at least what's shown here, and it's hovering around 50% of eligible women. So the study I'm going to talk about is based on data from one of the big HMOs in Israel, which are sort of all the titles here, the railway. Israel has a universal healthcare coverage of all residents, citizens or not, through 4 HMOs. And screening exams for early detection of cancer are routinely done following the preventive medicine guidelines, which I'll mention in a minute. I just want to know that Israel implemented a national program for quality indicators in community health, which continuously measure healthcare quality of preventive services, including screening, treatment, management of disease. That includes also diabetes, heart disease, but also screening for cancers. And the goal is, of course, to improve the quality of care provided. Now, these indicators are assessed, like I said, for the various screening for cancers, where the screening for breast cancer with mammography started in 2002, for colorectal cancer in 2004, and for cervical cancer in 2015. Now, the way it works, the results showing the annual performance of each HMO is given published, like for the general audience, and also given to the HMOs who discuss it and try to adopt various strategies to improve screening rates and improve the quality indicators. Okay, now, what I'm going to show you, focusing on individual women. And what we're interested in is to see, following a period of 15 years, what portion of this period women keep current adequate screening status. And this is something that is more difficult to examine because the data is, kept by the HMOs. It's not easily available, but this was done in collaboration with this HMO. And furthermore, we're interested in looking at screening behaviors across domains. In this study, particularly looking at the joint screening patterns for both breast cancer and colorectal cancer. And of course, once we have more data, we can add the cervical cancer, although it's slightly different age range for eligible women. So we wanted to highlight common patterns and identify subgroups that could be targeted for more effective intervention. The study included actually like over 200,000 women. For this study, we focused on the almost 100,000 women aged 50 and over that had at least 3 years of follow-up. We have records of screening for breast cancer and colorectal cancer between 2000 and 2014, so that's 15 years of data. For breast cancer screening, we looked at percent of women aged 50 to 74 who had at least one mammogram in the last 2 years. For colorectal cancer, we assessed percentage of women aged, again, 50 to 74 who had either fecal oral blood test performed in the last year or colonoscopy during the past 10 years, and that's according to the recommended guidelines. use also survival method to look at factors associated with the exams, but I'm not going to get into this in detail. So over 15 years of follow-up, we found that 88% of women had at least one mammography. That means that 12% of women had no mammography at all over 15 years of follow-up. The average follow-up was between like 7.5 or 8 years, so it's not like short follow-up. For colorectal cancer, it was 80%. We had at least one screening, either colonoscopy or fecal blood test. The median time to first screening for mammography from the age of 50 was 1.7 years for women, but for breast cancer. But for colorectal cancer screening, it was almost 8 years, 7.7 years from age of 50 when women first started doing the screening. So this is kind of part of the data, and it needs a little bit of explanation you see in the graph. So can you see my cursor still?
Yes.
Mm-hmm. Yes, you can.
Yeah?
Yes, you can.
Yeah, okay. Okay, so on the left, you see all women, and we had 9,256 who had exactly one mammogram during follow-up. I'm showing you for mammogram, but you can show the same graphs for colorectal cancer screening. So you can see the gray, each line represents one specific woman. They just ordered arbitrarily from the time of first mammography, so it's kind of easy to see the pattern. And you can see the different follow-up times, because it doesn't all end, 15 years, because some children earlier get into the pool a little later. So for this group, that composed 11% of women that had at least 5 years of follow-up, the average coverage was 21%. That means that these women had about 2 years out of the total follow-up they were current in their screening for breast cancer. Okay? When you move to the right, to the middle group, this is a group that had exactly 2 mammograms during follow-up. And you can see the 2 kind of strips of green. The green indicates the time from mammography up to 2 years after that, since women are supposed to be current with their screening for 2 years after they do mammography, right? Does that make sense? Okay, so you see the 2 strips now because they've done 2 mammographies, but you can see there are some mammographies that were done later on. It's hard to see because I have over 14,000 lines on this graph, okay? But you can see that there are, screening tests that were done with a larger gap from the first one. So women don't necessarily go exactly after 2 years to do another mammogram. Some of them delayed and they may have no time to do anything else. And similarly, we have a group that had exactly 3, etc. It's hard to kind of follow all this, but what I want to show is how we calculate the proportion of time where women were current or have adequate screening. Okay, so it's for every mammogram, you look 2 years forward. So the average percent of the period covered was 21% for the first group, about double that, 42% on average for the second group is 2 mammograms, and about 3 times more than 58% for the group with exactly 3, and we can go on and on. Of course, I'm just going to show you this to give you an idea. Now, okay, let me go. So think about this type of calculation where we look at the green proportion for each horizontal line, which represents a woman, and we do the same for colorectal screening. So now what we wanted to do is look at the joint distribution of coverage. Because you can ask yourself, women that do regular mammograms, so they are aware of the risk of breast cancer, they follow these guidelines, aren't these women also keeping good screening behavior for colorectal cancer, which is totally different? And we see that the answer is definitely not. So what you see in this colored graph is like a 3D picture. So the x-axis shows you the mammography coverage. So that's, women that had that covered only 20% of the follow-up period or 60% of the follow-up period, etc. On the y-axis, we have the same coverage proportion, but for colorectal cancer. So either they had colonoscopy or FOBT. Now, instead of showing you like columns with height according to frequency, I'm showing you a heat map where the color red, the more red it is, the higher the frequency, and the more blue it is, the lower the frequency. So what you see, first of all, in the corner here, you have about 8% of women that have no screening at all, no mammography and no screening for colorectal cancer throughout this period. Then you have like the nice kind of flower here with the center being deeper red, and that corresponds to coverage of mammography around, let's say, 50% to about 80%, okay? But these women had very low coverage for colorectal cancer. So these probabilities here would be around like 7, 8%, 10%. And similarly, we have another group of women that were kind of okay with mammography, but had almost no screening for colorectal cancer. Now, this group that has maybe 0.1% of this population, they did a lot of screening for colorectal cancer, but almost no mammography. Okay, so that helps to see the joint behavior of women when they consider screening for different types of cancer. And in this example, we took the most common cancers. So, and there are factors related to screening, which is older age, ethnic, cultural minority groups tend to do less screening, also lower socioeconomic status, etc. The main conclusion I want to highlight is that when we talk about a national policy for early detection of cancer, I think the recommendation is not to focus on specific types of cancer, but rather women. So, and we had this, discussions with the HMO leadership and said, once women turn 50 for this type of cancer, these women should have a conversation with a healthcare provider and understand that they have to start a structured routine screening for all types of cancer that is relevant for them, of course, when screening is available, whether it's breast, colorectal, cervical, whatever we can do. And that's something that I hope is going to be implemented and considered. So just some additional notes. Of course, we see that the screening for colorectal cancer is much lower than breast cancer, again, probably because of awareness after many campaigns, and also screening among minorities and lower socioeconomic status needs to be improved. Thank you, and I hope it made sense. And I just want to know that this work was also supported in part by Ivan from the Tigray Science Foundation. Thank you.
Thank you, Noya. Are there any questions for Prof. Galal? I think your presentation has been very, very clear, Noya, and thank you for taking the time to join us. As you see, the contribution you made even to Mariella's study, is very, very, very important to continue helping. Thank you.
To be continued. Thank you.
Thank you so much.
Okay.
Thank you. Okay, so we move on to our last speaker. Yes, who is Professor Lyube Ivkovsky, yes, from the University of North Macedonia. And the lecture is going to be on fine needle aspiration cytology of the breast and cell blocks, the experience in North Macedonia. So we're very keen to hear from you. Thank you.
Can I make one comment? You start because the university has sent Cyril and Methodius in Skopje. It's not University of North Macedonia. And Professor Ivkovsky is actually affiliate now. He's working in a private company. But nevertheless, it's St. Cyril and Methodius. Okay, thank you.
Okay, thank you for comment. Hello, everybody. Thank you for this opportunity for giving me to give the lecture here. The topic is about fine needle aspiration cytology of the breast and cell blocks, which is quite similar to the cell core needle biopsy, which we are doing on breast also. And I will show my experience with this type of method and cell blocks. And I must say that I work with this technique almost 30 years. And I perform fine needle aspirations and also interpret the result of the fine needle aspirations, and I think it is the best way to achieve the best results. As we know, all the diagnosis of the breast lesions are in fact triple test, which is comprised of clinical examination, imaging techniques like mammography or ultrasound, and core needle biopsy, which is today much widely accepted, and fine needle aspiration cytology or biopsy, which is also in these days diminished in use. But there is this place for fine needle aspiration in the evaluation of the both palpable, especially palpable, but also non-palpable breast lesions. And we can see some examples during the presentation. Fine needles are for just a few notes for fine needle aspiration. It is quite inexpensive method. This is quick. I can give the result for the women about the breast lesion within 2 hours. On the other hand, with core needle biopsy, it will take maybe 3, 4, 5 days. It is accurate and efficient tool in the proper hands, and this is well tolerated by the patients. It is reliable and useful for the planning of the surgical or oncological treatment of the patients. What are the indications for the fine needle aspiration of the breast? Usually we aspirate cyst, which is some diagnostic and treatment option. In the case of previously diagnosed breast cancer, which there is a recurrence or metastasis, which is in very difficult places, which can be not reached by the core needle biopsy. In order to confirmation of advanced breast cancer, for example, for inoperable breast cancer, and also fine needle aspiration is used as a guide for further clinical management in palpable breast lumps. And with this method, we can obtain also cells for immunohistochemistry, and further molecular analysis can be done. Which are advantages of the breast fine needle aspiration? It is the first of all cost. It is minimally invasive procedure with a few complications. Very rare can be seen bleeding and infection. And with core needle biopsy, you can see also bleeding and infection, which is much bigger needle. And also we can obtain material for further analysis, and also we can obtain a very rapid diagnosis, but there is some limitation. Accuracy of fine needle aspiration biopsy is highly operator dependent, I think, and it's much better. The operator and the interpreter of the cytology report should be the same person. We use Cameco syringe holder with syringe and needles. Needles are from different size, from 80 gauge, which is quite big, which is almost similar with the core needle biopsy, until to very small thin needle, about 26 gauge for small lesions. And with these needles, we use usually 21 or 23 to obtain good material, and also material for the cell blocks, which can be shown in the further explanation. This is an example for classical example of fine needle aspiration cytology of the breast carcinoma. This is cytomorphology. We can see malignant cells, which have all the signs for malignancy, and we can easily establish diagnosis of breast carcinoma. But of the rest of the material, which is in the syringe and the needle, usually we throw it, but if we want, we can make from this material nice cell block, like here, with plasma thrombin method, and we can obtain histological material, which is can be taken, can be sectioned with the classical, like a classical histological biopsy, and we can obtain histological section from this material, which is quite similar with the core needle biopsy. We can see here histological section from the classical breast invasive ductal carcinoma, and the method was cell block with a thin needle, not with a big needle like with core needle biopsy. With this cell block technique, we can spare or save small tissue fragments in the fluid sample, and they can be processed like normal histology. In these fragments, we can see the preserved tissue architecture, and with these fragments, we can improve our diagnostic accuracy, and also we can take further multiple sections with the same cell variety, and another analysis can be done, like immunohistochemistry and molecular analysis on this cell block. And combined use of cell block technique and fine needle aspiration is largely increase the sensitivity of this method, almost 95 to 100%. We use plasma thrombin method. In the world, they use different methods, but widely used is plasma thrombin method. And with this cell block, we can see that it closely resembles to the corresponding histological biopsy. There is excellent detail of the cells, clarity and delineation of the cells with nuclear and cytoplasmic details. Sometimes we can see a lot of preserved architecture of the cells. Sometimes in the papillary neoplasms, we can see even papillary structures. And we can use on this cell block material wide type of techniques like histochemistry, immunohistochemistry, and molecular analysis. This method is simple, reproducible, and adaptable in the routine work of the diagnostic laboratory. We use the reporting of the breast fine needle aspiration Yokohama system, which is from that, it is published, this book is published about 2018, I think. It is under the guidance of International Academy of Cytology, and they put the results in 5 categories, which is insufficient and inadequate, which there is not cells, for example, to make the diagnosis, and with the recommendation to repeat the procedure. The second one is benign, the typical, suspicious for malignancy, and malignant. We use almost the same classification, but this is our classification, which is almost 50 years old. It starts with our one old professor, Professor Stavric, which is C nulla, C0 is inadequate when the procedure should be repeated. C1 normal, C2 benign with inflammation, C3 undeterminate lesion with atypia, but foul benign lesion, C4 is malignancy suspected, and C5 is malignant lesion. When we evaluate the specimen, we usually, first of all, we go to the low power to see cellularity, cellular arrangement, and background elements. And on high power, we see the type of single cells or group of cells, their nuclear characteristics and cytoplasmic characteristics. And then we establish diagnosis. This technique can be used in a wide spectrum of disease of the breast, especially in benign condition of the breast with fibrocystic change, fibroadenoma, in pregnancy and lactational changes, in cases of fat necrosis, radiation changes, mastitis, subarachnoid abscess, and gynecomastia in males. When we're dealing with fibrocystic change, they are divided in two big groups, non-proliferative fibrocystic change and proliferative fibrocystic change. These non-proliferative change are significant. There is no significant interductal hyperplasia. Lesion is predominantly fibrous. We can see here apocrine cells, foam cells, and small ductal cells. And this is an example of one non-proliferative fibrocystic disease. This is aspirated from the cyst, breast cyst, in which there is a fluid in which there is a lot of apocrine metaplastic benign cells. One from the left side is Papanicolaou stain, and from the right side is Gimza stain. In proliferative fibrocystic disease, the case is much difficult. There is atypia of variable degree. There is florid ductal and lobar hyperplasia, and in these proliferative ductal lesions, there is a lot of crowding and nuclear atypia, and this is examples of aspirates from the lesions without atypia from the left side, where there is ductal epithelial cells which is evenly spaced with small nuclei. On the right side, there is atypia which are in different, there is larger nuclei, hyperchromatic nuclei, and this is suspicious for malignancy. But this is histology section from the proliferative breast lesion. We can see a lot of proliferations here, intraductal with papillary proliferations, some dilated ducts with apocrine metaplastic cells and foam cells, and etc. And this is all elements we can see in fine needle aspirations, but this is histological section. But when we are dealing with some proliferative lesions like sclerosing adenosing, it is quite difficult to establish the diagnosis on the fine needle aspiration. Then it is much better to take out the lesion and to perform by surgeon lumpectomy and to examine the tumor on histological paraffin-embedded tissue. When you're dealing with fibroadenoma, it's much easier question. Most common benign tumor of the female breast. It can be seen in the woman in any age, but usually in younger patients. It is freely movable, circumscribes rubbery mass, and results from stromal and glandular proliferation. This is the example of cytomorphology of the fine needle aspiration of fibroadenoma. It is hypercellular smear, large honeycomb structures, 3D clusters, and etc. But there is regular nuclei, lot of background bipolar nuclei with piney granular chromatin and small round nuclei, and this is classical example of fibroadenoma. And this is the fibroadenoma taken out, and this is histology section from fibroadenoma. Sorry?
Someone unmuted and talked.
Yeah, okay. Sorry. Fat necrosis can mimic carcinoma, both clinically and mammographically, but the history of the patient is very important. If you take good anamnestic data, you can see there is some history of previous surgery in the lesion in this region of the breast, or maybe trauma in the breast, but sometimes there is no data. But when we obtain cytological material from this type of lesion, you can see that there is hypocellular material, a lot of necrotic fragments in the smear, with a lot of histiocytes, some necrotic lipocytes, but usually it is almost necrotic lesion. And this is histology, the tissue was taken out from the surgeon, and this is a lot of proliferative macrophages with foamy cells and a lot of lymphocytes which are necroticytes. When we are dealing with papillary neoplasm, also the question, also there is a difficulty to establish sometimes the diagnosis. When there is a benign intraductal papilloma, which it is usually solitary, I think that it can be established very well. The diagnosis, usually these patients have blooded nipple discharge and can be present in like a subareolar mass which requiring for fine needle aspiration. But it is something difficult to establish and to make differences between papilloma and papillary carcinoma, and sometimes, but it's difficult, it is better to recommend excisional biopsy. This is the characteristic which favor benign papillary neoplasms and favor malignant. I will not go into details here because it is mainly for pathologists. But we can see the pictures from these two types of lesions. From the left side is papillary lesion obtained by fine needle cytology. We can see three-dimensional clusters without fibrovascular core, a lot of background cells, naked nuclei, macrophages, etc. From the left side, this is cell block material from the same lesion, and we can see tissue fragments with preserved architecture, like from papillary structures with fibrovascular core and benign epithelium, which is lined on these papillary structures. And afterwards, this is the cell block from the same case. We put immunohistochemistry on cell block, and we can see that this fibrovascular core can be easily visualized by alpha-smooth muscle actin. The epithelial cells can be easily visualized by the cytokeratin 7 and also epithelial membrane antigen. And the level of proliferativity was Ki67 was very low, and the diagnosis was benign intraductal papilloma. The lesion was taken out, and this is the same patient with the tumorectomy, and this is benign intraductal papilloma. We can see this big dilated duct linked by the atrophic epithelium, but inside the duct we can see a lot of papillary proliferations, which is in fact benign intraductal papilloma. Phyllodes tumor is quite difficult for diagnosing on fine needle aspiration. It is biphasic tumor like fibroadenoma, but there is a lot of epithelial stromal proliferation. It is a very rare tumor, less common than fibroadenoma. It can be benign and malignant, and there is a lot of stromal hyperplastic cellular component with a stromal atypia, sometimes with numerous mitotic figures, and sometimes can be also proliferative epithelial atypia, which can mimic carcinoma. This is fine needle aspiration from tumor measuring about 4 centimeters in diameter with epithelial proliferation from the left side, and from the right side it's cellular stroma. In the stroma there is a lot of stromal fibroblast, but without atypia and no mitosis, and it can be suggestive that it's dealing with benign Phyllodes tumor. This is cell block from the same case. We can see the stroma is cellular, but the stromal cells, they're uniform, fusiform, and there is no nuclear polymorphism, there is no mitosis, and on the right slide, there is small stromal epithelial element, epithelial element, which is also lined by benign cells. This is histology from the same case. We can see a lot of finger-like projections from the stroma, which is almost the same constitution like in the cell block, and there is no nuclear polymorphism, no mitosis, and this is benign Phyllodes tumor. This is an example from the malignant Phyllodes tumor, in which there is stroma with marked cellularity, with a lot of stromal cells which show nuclear polymorphism, and this is cell block from the same case, in which the stroma is markedly cellular, the stromal cells are tightly packed with nuclear pleomorphism and mitotic figures. And from the left side, the epithelial component, which is benign in this case, but the stromal neoplasm is, the phylloderstoma is in fact a stromal neoplasm. And this is the operative material from the same case. We can see the same stromal element, which are tightly packed fusiform from malignant cells, which can be easily established on the histological section. Now we can come to the question of carcinomas of breast, of most common types. There are invasive ductal carcinoma, lobular carcinoma, medullary carcinoma, mucinous or colloid carcinoma, tubular carcinoma, and metaplastic carcinoma. There is also special types of carcinoma, but this is the most common cancers which can we see in our daily practice. Invasive ductal carcinoma is measuring about 65 to 80% of all breast cancers. It is solid, palpable usually, with a gritty consistency, and sometimes may result in non-diagnostic fine needle aspiration because if there is a serous carcinoma with dense fibrosis, it is difficult to obtain malignant cells, but it is not usually. This is classical example of fine needle aspiration smears from the invasive ductal carcinoma. Usually the smear is hypercellular. There is a lot of clusters or individual malignant cells with eccentrically placed nuclei, hyperchromatic, with all characteristics of malignancy. From the left side there is a smear stain by Papanicolaou stain, and from the right side is Gimza stained smear. This is the cell block from the same case, tightly packed malignant cells on which we can apply immunohistochemistry, and we can have the same result like a core needle biopsy. We can see in the second row from the left there is estrogen receptor positive cells, there is progesterone receptor positive cells, Ki67, which is not very high, P53 is negative, and from the last two slides are HER2, which are HER2 positive, and we can see that even with fine needle cytology, with cell blocks, we can obtain the same information like in core needle biopsy. Invasive lobular carcinoma is breast cancer, which is usually 5 to 10% of all breast cancers. Differential diagnosis is usually with well-differentiated ductal carcinoma or tubular carcinoma. It is difficult to diagnose by fine needle aspiration because of scan cellularity, and with fine needle aspiration you cannot distinguish invasive lobular and lobular carcinoma in situ. This is an example of invasive lobular carcinoma, small cells with a lot of intracytoplasmic vacuoles, which displace the nucleus on the periphery of the cells. From the left side, the Papanicolaou, from the right side, the Gimza stain. Very cellular smear, and easy you can put the diagnosis of invasive lobular carcinoma. This is the cell block from the same carcinoma case. You can see tissue architecture of the carcinoma, tightly packed small cells, and on this cell block you can also put immuno in order to obtain breast carcinoma panel. This is the operative material from the same case. This is small cells, tightly packed, Indian file formations, elastosis around the ductals, and etc., fibrosis, and diagnosis is in well-differentiated invasive lobular carcinoma on histology on operative material. Medullary carcinoma is also a rare carcinoma. Usually it's a big lump, well circumscribed, can be mistaken clinically by fibroadenoma and mammography also. It is usually, we can obtain large, poorly differentiated cells with scan stroma, and sometimes there is marked lymphoid infiltrate. Usually there are medullary carcinoma with lymphoid infiltration. Can be cystic, can be hemorrhagic, and can be see some part of necrosis. And sometimes when we obtain a lot of inflammatory cells, but very scant amount of malignant cells, differential diagnosis can be chronic mastitis, inflammatory lymph node, intramammary lymph node, or lymphoma can be put on the diagnosis. But this is medullary carcinoma, huge malignant cells, big cells with hyperchromatic nuclei, scan cytoplasm, and all characteristic of malignancy. But there is a lot of sparse small cells behind this big population of malignant cells. This is a lymphocytes, and this is invasive ductal carcinoma with lymphoid stroma. This is cell block from the same case. We can see the large cells were not well. They are not too much present, but most of this cell block consists of lymphoid infiltrate. This is in fact medullary carcinoma with lymphoid stroma, and this is the next carcinoma is mucinous carcinoma, which is also very rare carcinoma. 2% of all invasive breast carcinoma. There is mucin production, but sometimes some invasive ductal carcinoma also they show focal mucinous differentiation. It is in the differential diagnosis with invasive ductal carcinoma with focal mucinous differentiation. This is a pure population of aspiration from colloid carcinoma. A lot of malignant cells tightly packed, but in the cytoplasm there is a lot of vacuous, mucinous vacuoles. This is the reason because colloid mucinous or colloid carcinoma. And this is the cell block from the same case. We can see a lot of mucinous mass in which are embedded these small groups of malignant cells. This is a colloid or mucinous carcinoma. Tubular carcinoma is also very rare carcinoma. This is well-differentiated tumor. It consists of well-defined tubules linked by a single layer of neoplastic cells. There is no basal cells or myoepithelial cells. It has better prognosis than invasive ductal carcinoma. And in cytomorphology, we can see there is a lot of tubular structures here. These are tightly packed cohesive twisted tubular structures in the cytology, and in this tubule we can see the lumen, in fact, in this cytology example. And with these slides, easily we can put the diagnosis of tubular carcinoma. This is the operative material from the same case, a lot of tubules and fibrous dense stroma, well-differentiated tubular carcinoma. Very rare carcinoma, adenoid cystic carcinoma, is almost 0.1% of all breast carcinoma. Usually, we can see adenoid cystic carcinoma as a salivary gland tumor, but we know that breast is salivary gland appendages. Its origin from salivary glands. And morphologically and cytologically, it is identical to adenoid cystic carcinoma in salivary glands. It has excellent prognosis. I like the prognosis in salivary glands, which is much more worse. This is the cytology from the adenoid cystic carcinoma, numerous single and group cells with scanty cytoplasm, round nuclei, and there is solid eosinophilic spheres or globules. There's errors there with these solid eosinophilic globules, in which can easily be assigned to establish the diagnosis of adenoid cystic carcinoma. This is the cell block from the adenoid cystic carcinoma. There is a dual population of cells here in cell block, luminal or ductal epithelial cells and myoepithelial basaloid cells, and can be easily stained by immunohistochemistry, in which these tubules can be stained by collagen 3, collagen 4. Epithelial cells can be stained by cytokeratin 7. Myoepithelial cells can be stained by P63, and also adenoid cystic carcinoma is positive for CD117. This is the operative material from the same case, radical mastectomy. There is a lot of basaloid cells arranged in a cribriform pattern with scattered ductal elements, and this is this is example with a lot of hyaline membrane here, which are lining the pseudolumina within the tumor. This is in breast, tumor with a good prognosis. And also in breast, we can see other uncommon breast tumor like non-Hodgkin lymphoma, diffuse large B-cell lymphoma, follicular lymphoma, multiple lymphoma. Also, we can see, but very rare, sarcoma like malignant fibrous histiocytoma, liposarcoma, even osteosarcoma we can see, but rhabdomyosarcoma, angiosarcoma also but usually in the patient who was previously have radiotherapy. Metastatic tumor from lung, hepatocellular carcinoma can metastasize in the breast. Melanoma, I have seen several cases with melanoma. Renal cell carcinoma can also give metastasis to the breast. As in conclusions, we can say that it's our opinion that fine needle aspiration is a highly accurate procedure for differentiating benign and malignant breast lesion in the proper hands. Sometimes specific cytological diagnosis may be difficult to make in absence of characteristic architectural pattern, and diagnosis of aspirates from cystic lesions may be less specific than the solid lesions. It is due to paucity of specific lesional cells and superimposed infection. And with cell block technique, it is simple, it is inexpensive procedure. It allows processing a minute amount of cellular material, which is as a rest material of the syringe and the needle. It can facilitate the better classification of breast lesion when it can be reviewed along with cytological smears. And these cell blocks could be utilized as the effective diagnostic tool in diagnostic workup of the breast lesion. And whenever is possible, it is advised to perform cell block for each case in order to decrease the pitfalls and to improve cytological diagnosis. Thank you.